Chapter 26, Treatment of Diabetes Mellitus. Diabetes mellitus is a disorder of metabolism that involves glucose use. It is a chronic condition in which the body cannot properly use glucose as energy. Glucose is the body's primary energy source. Under normal conditions, as glucose levels in the blood rise, hormones are released that move the glucose out of the bloodstream and into cells, where it is needed for growth and energy. In diabetes, glucose accumulates in the blood, much like a person with sticky hands walking through a room. Insulin, a hormone that is essential for the regulation of carbohydrates, fat, and protein metabolism, is secreted by the beta cells in the islets of Langerhans when the blood glucose level rises. Insulin, along with glucagon, is released by the pancreas in response to the rise and fall of blood glucose, amino acid, and gut-derived hormone levels. Figure 26.1 shows the role of insulin. Excess glucose that is not needed for energy immediately is stored in the liver as glycogen, a reservoir for future energy needs. When glucose levels drop, glucagon is secreted by alpha cells in the islets of Langerhans. Box 26.1 shows physiologic effects of insulin. Prediabetes, type 1 diabetes, type 2, and gestational diabetes all produce elevated blood glucose levels, hyperglycemia. A normal fasting blood glucose level is 70 to 99 milligrams per deciliter, or less than 4 to 6 mmol per liter. Symptoms of hyperglycemia are listed in box 26.2. So that's when your blood sugar is too high. Prediabetes causes impaired fasting glucose and impaired glucose intolerance. Type 1 diabetes is an autoimmune disease. The immune system attacks and destroys the insulin-producing beta cells in the pancreas. Only 5 to 10% of all people with diabetes have type 1 diabetes. People who have type 1 diabetes must inject insulin daily because their body no longer produces sufficient amounts of the hormone insulin. The onset of type 1 diabetes is typically in childhood. Hence, the condition was formerly called juvenile onset diabetes mellitus. However, it can occur at any age. Type 2 diabetes is most common, accounting for 90 to 95% of all diabetes cases. In type 2 diabetes, the pancreas initially produces sufficient amounts of insulin, but the body is unable to use the insulin effectively. This condition is called insulin resistance. Insulin production eventually decreases. However, this might not occur for several years. Risk factors for type 2 diabetes are obesity, lack of physical activity, family history of diabetes, prior gestational diabetes, and increasing age. Approximately 80% of people diagnosed with type 2 diabetes are overweight. So table 26.1 shows the risk factors for diabetes mellitus. We have non-modifiable, modifiable, and then disease risk factors. Gestational diabetes occurs in approximately 3 to 8% of all pregnant women. It typically occurs late in pregnancy and may be caused by the hormones of pregnancy or by a shortage of insulin. Insulin resistance is a condition in which the body does not respond to insulin. It is a precursor to type 2 diabetes. Box 26.3 shows the symptoms of diabetes mellitus between type 1 and type 2. The hemoglobin A1C test is the principal method used to diagnose diabetes. It is the only test that provides information about blood glucose levels over a 2 to 3 month period. Untreated or poorly uncontrolled diabetes mellitus produces damage throughout the body. It may cause microvascular and macrovascular damage. Microvascular damage weakens blood vessels in the eye, and retinopathy can lead to blurred vision and blindness. Nephropathy, kidney damage, and diabetic neuropathy also can occur. Diabetic neuropathy causes numbness in the lower limbs. Patients with diabetes most frequently inspect their feet because if they develop a foot injury, they might not feel it. Diabetes causes poor wound healing, so foot infections sometimes become serious enough to require limb amputation. Individuals with untreated or poorly controlled type 1 diabetes may develop ketoacidosis, a condition in which the body breaks down fats to obtain its energy needs. Ketones are byproducts of lipid metabolism, and their accumulation can lead to coma and death. Box 26.4 shows diabetes complications. All types of diabetes can be improved by weight loss, engaging in physical activity, consuming foods with a low glycemic index, quitting smoking, reducing alcohol consumption, and other lifestyle changes. Blood glucose monitoring is an essential component of diabetes management. Measurement of blood glucose levels may be recommended 1 to 4 times daily, depending on the type of diabetes and on the anti-hyperglycemic drug regimen that the patient is prescribed. Keeping the blood glucose level within a normal range has been shown to minimize the risk of diabetic complications. Simlin is a synthetic analog of the hormone amylin that is also used for the treatment of type 1 diabetes. Type 2 diabetes may be treated with oral agents and/or insulin, and oral anti-diabetic agents are indicated only as an adjunct to diet and exercise in the treatment of type 2 diabetes mellitus. Insulin is administered for the management of all types of diabetes. It helps the body metabolize carbohydrates, fats, and proteins from the diet. It may be the sole drug administered as in type 1 diabetes, or may be added to oral therapy or replace oral therapy in type 2 diabetes. Insulin was originally manufactured from animal sources like pig and cow. However, genetically engineered insulin using recombinant DNA technology to match human insulin has replaced animal source insulin. Pork and bovine insulins are no longer marketed in the United States. Remember when mixing insulin that if one is cloudy, it gets drawn up second. Lantus or Levemir should not be mixed together in a syringe with any other form of insulin. Rapid acting insulin or regular insulin and long acting insulin are clear solutions that should be discarded if they appear cloudy. Insulin facilitates the transport of glucose in the bloodstream into the body's cells where the glucose provides energy. Solutions such as regular insulin may be administered intravenously. All other insulins are injected subcutaneously. Insulin is formulated in rapid acting, short acting, intermediate acting, and long acting forms. The onset of action for rapid acting insulin begins with 15 minutes, whereas the onset of action for long acting insulin is 90 minutes. Rapid acting insulin is injected 5 to 15 minutes before eating or even after a meal for some individuals. Long-acting basal insulin administered at bedtime has the advantage of lower risk for nighttime hypoglycemia when compared with NPH insulin, which is also used for basal insulin needs. This chart 26.2 shows the onset, peak, and duration of action of all insulin. This is a really good chart to kind of understand the different types. Box 26.5 shows symptoms of hypoglycemia, so low blood sugar. Table 26.3 shows recommended storage for open vials and cartridges of insulin. So for insulin aspart, insulin glucosine, the vial should be discarded after 28 days and the cartridges as well. Insulin detamir, this one's important. This one is good for 42 days, and it's the only one that's like that besides some NPH insulins. And then we have all the insulins listed here. You can see all the different US brand names, which is kind of nice because there's quite a few now. And you can see all of these are solution for injection. However, the Afrezza is the insulin that can be inhaled. It's not very popular, but it is available. So that one is there. And then we have all the insulin mixtures. Box 26.1 shows that many drugs may produce hyperglycemia or hypoglycemia. So for drugs associated with hyperglycemia, for example, some of them beta blockers, growth hormones, phenytoin, atypical antipsychotics, and then drugs associated with hypoglycemia, acetylsalicylic acid like aspirin, alcohol, beta blockers. Sulfonylureas are sometimes categorized as oral hypoglycemic agents. They are effective only for the treatment of type 2 diabetes. Sulfonylureas primarily stimulate insulin release from pancreatic beta cells. Sulfonylureas also decrease the breakdown of glycogen to glucose. Glycogen is a storage form of glucose. So for sulfonylureas, we have those all listed here, like glyburide, glipizide. This one here is not available in the US. We won't talk about that. And glimepiride. Metformin is classified as a biguanide anti-diabetic agent. Metformin acts to control fasting blood glucose. It is effective in producing glycemic controls and reduces HbA1c levels by 1 to 2% without producing hypoglycemia. This makes metformin a first-line drug for the treatment of type 2 diabetes. Unlike most other anti-hyperglycemic agents, metformin does not cause weight gain, which is a benefit when treating obese patients with type 2 diabetes. Metformin improves glucose intolerance and insulin resistance by increasing peripheral glucose uptake in skeletal muscles and adipose tissue. It increases glucose transport across cell membranes. Metformin also lowers postprandial plasma glucose levels, decreases hepatic gluconeogenesis production, and decreases intestinal absorption of glucose. So we have all of the different brand names for metformin, their dosage forms and strengths, and then we have some combinations with metformin and glyburide and metformin and glipizide. Alpha glucosides inhibitors prolong the digestion of carbohydrates and delay their absorption into the small intestine. They reduce peak plasma glucose levels. So we have Precoce and Glycet here for the alpha glucosidase inhibitors. Meglitinides are oral anti-diabetic agents used in the treatment of type 2 diabetes. Meglitinides, like the sulfonylureas, are effective only in individuals who have functioning pancreatic beta cells. A common ending for meglitinides is glenide, and repaglenide and nataglenide lower postprandial blood glucose levels by stimulating insulin secretion from pancreatic beta cells. Repaglenide is rapidly and completely absorbed from the intestinal tract. The onset of action is within 15 to 30 minutes. Meglitinides may cause hypoglycemia. However, the risk is lower than with sulfonylureas if they are taken appropriately with meals. So we have Starlix and Prandin, the brand names. They're available in tablets only. Thiazolidinediones are insulin sensitizers. They are used for the treatment of type 2 diabetes. They treat insulin resistance. Two agents are currently marketed, pioglitazone and rosiglitazone. Both drugs reduce fasting plasma glucose, FPG, and HbA1c levels by approximately 1 to 2%. A common ending for those is glitazone. They increase tissue sensitivity to insulin, and pioglitazone and rosiglitazone increase the uptake of glucose in the liver and muscles. So we have those listed here. And the pioglitazone and the rosiglitazone are only available in tablets. And then we have some combinations of pioglitazone and metformin and pioglitazone and glimepiride. Dipeptidyl peptidase 4 inhibitors, algogliptin, linagliptin, saxagliptin, and sitagliptin are oral anti-diabetic agents known as dipeptidyl peptidase 4 inhibitors, which we commonly abbreviate as DPP4 inhibitors. They are indicated for the treatment of type 2 diabetes. They increase insulin release and decrease glucagon levels by potentiating the activity of peptide hormones released in response to eating a meal. A common ending for DPP4 inhibitors is gliptin. So we have those here: Nasina, Trajenta, Onglyza, Januvia, and then we have some combinations. Kazano is alogliptin and metformin. We have one with linagliptin and metformin, saxagliptin and metformin, Combiglize XR, sitagliptin and metformin like Janumit and Janumit XR, and alogliptin and pioglitazone like Osenzi. Canagliflozin, dapagliflozin, empagliflozin, and ertagliflozin are sodium glucose cotransporter inhibitors, which we abbreviate as SGLT2 inhibitors that are used for the treatment of type 2 diabetes. Gliflozin is a common ending for these medications, and they're listed down below. And we also have some combination ones: canagliflozin and metformin, dapagliflozin and metformin, epagliflozin and metformin. And you can see there's quite a few more. Trulicity, Byetta, Victoza, and Ozempic are parenterally administered agents. Glucagon-like peptide receptor agonist drugs, we abbreviate those as GLP-1, are administered as adjuncts to diet and exercise and may be administered only for type 2 diabetes. And we have those listed here. They're all solutions or injections, solutions for injection, sorry. Similan is the synthetic analog of the hormone amylin. Amylin levels are absent in type 1 diabetes and decrease in type 2 diabetes. Similan is used with mealtime insulin to control blood sugar levels in people who have type 1 or type 2 diabetes. We should rotate the site of injection to minimize risk of developing an increase or decrease in fatty tissue under the skin at the injection site. So we have that listed here. It is a solution for injection. Welchol is a cholesterol lowering agent that is FDA approved for the management of type 2 diabetes. Cycloset is a dopamine agonist that improves glycemic control. The mechanism of its effect on postprandial glucose levels is unknown. Both drugs are approved as an adjunct to diet and exercise. So we have bromocriptine listed here, which is Cycloset. Some medications used to treat diabetes cause hypoglycemia, especially when individuals increase exercise, do not eat regularly, or take other medications that can also decrease blood sugar. Individuals experiencing symptoms of hypoglycemia may raise their blood sugar by consuming 3 to 4 glucose tablets or a tube of glucose gel, 1 tablespoon of sugar, honey, or corn syrup, 4 ounces of juice or regular soda, not diet, or 8 ounces of non-fat milk or 1% milk. Eat several hard candies, jelly beans, or gumdrops. Severe hypoglycemia is treated by administering the hormone glucagon. It is administered by intravenous or intramuscular injection. Glucagon kits are available by prescription only. The kit contains 1 vial with a 1 milligram glucagon powder and a vial of diluent. 6 dietary supplements have been of particular interest in recent years as adjunct therapy for people with diabetes. They are alpha lipoic acid, chromium, coenzyme Q10, garlic, magnesia, and omega-3 fatty acids. Alpha lipoic acid is an antioxidant. Antioxidants prevent cell damage caused by oxidative stress from substances called free radicals. Magnesium is a mineral found in green leafy vegetables, nuts, seeds, and some whole grains. Magnesium levels are depressed in people with diabetes. Low magnesium levels may worsen glucose control in type 2 diabetes by interrupting insulin secretion and increasing insulin resistance. Omega-3 fatty acids are naturally found in fish, fish oil, canola, and soybean oils, walnuts, and wheat germ. Evidence about the value of garlic is mixed. It is believed that garlic may be involved in some biologic activities associated with type 2 diabetes. We have the summary of drugs used in the treatment of diabetes, which we've went through all of these, but we have the warning labels that you can look through. But it kind of has, like, for the Afrezza, discard 14 to 15 days after use, only use Afrezza cartridges, do not freeze. For the sulfonylureas, for glyphosate and glyperamide, you should avoid prolonged exposure to sunlight, limit or avoid alcohol for all of them. Take 30 minutes before breakfast, glyphosate and glyburide. Take with a meal for glyperamide. And for the biguanides, you should take with meals. And of course, that's the same with the combinations involving biguanides. For the alpha glucosidase inhibitors, take with the first bite of a meal. For the DPP4 inhibitors, take at the same time each day with or without food. For the meglitinides, take immediately prior to meals. Skip dose if the meal is missed. For pioglitazone and rosiglitazone, you should limit or avoid alcohol and take with a full glass of water. Refrigerate, do not freeze, discard pen 30 days after opening for Victoza and Byetta. For Byetta, you should inject 60 minutes prior to morning and evening meal. For the Bitaron, use immediately after reconstitution and do not use diluent if cloudy for the Bitaron. For the Invokana, you should take 1 hour before the first meal of the day. You should avoid alcohol and take with food. For the Invocamet, and any of these other ones here. For the amylin, analog, Simlin, refrigerate, do not freeze. And for cycloset, that should be taken with food.